fatigue for several months and has noticed recently that the waistbands of his pants are tight in spite of a 15-pound weight loss. He has not had a diarrhea, nausea, vomiting, or other gastrointestinal symptoms. He does not take any medications and denies using illegal drugs. He underwent blood transfusion with several units in 1982 after an automobile accident. Physical examination reveals generalized jaundice, a firm nodular liver edge just below the right costal margin, and a mildly protuberant abdomen with a fluid wave. Initial laboratory studies show the following. So the alanine aminotransferase, here are the values: alkaline phosphatase, aspartate aminotransferase. As you can see the values in your screen. Albumin, bilirubin serum total, bilirubin serum direct, prothrombin time, and partial thromboplastin.
Kindly indicate which is increased or decreased.
So first is your alanine aminotransferase is increased. As you can see, uh, the reference range is 8 to 20 and the patient's value is 80. While your alkaline phosphatase, it is normal because the reference range is 20 to 70 while the patient's value is 60. And next is your aspartate aminotransferase increase. Normal reference value is 8 to 20. And albumin is decreased. Normal reference range is 3.5 to 5.5. And bilirubin serum total also increased. Bilirubin serum direct also increased. Prothrombin time increased. And partial thromboplastin increased. Next slide. So silent features include 57-year-old male patient, fatigue for several months, noticed tightening of his pants in spite of a 15-pound weight loss, no diarrhea, nausea, vomiting, or other GI symptoms, no current medications, no drug use, underwent blood transfusion with several units in 1982, jaundice, firm nodular liver edge on physical exam, mildly protuberant abdomen with positive fluid wave, elevated liver enzymes, hypoalbuminemia, elevated prothrombin, and PTT.
For our final diagnosis, we have cirrhosis secondary to chronic HCV infection. Persistent infection and chronic hepatitis are the hallmarks of HCV infection, despite the generally asymptomatic nature of the acute illness. For the differential diagnosis, we have liver failure and bile duct obstruction. All are increased. For HCV, all are increased except alkaline phosphatase, which is normal, and albumin, which is decreased. This is supposed to be decreased. And they are similar except in alkaline phosphatase and albumin, wherein in liver failure and bile duct obstruction, both are increased in albumin while it is decreased in the case we have here. And for alkaline phosphatase, it is increased in liver failure and bile duct obstruction, but it is normal in the case that we have. This is a comparison between the different types of hepatitis viruses based on their relative frequency, route of transmission, incubation period, tendency to form a chronic state or carrier state, and their serologic markers. For relative frequency, hepatitis A is 25% of the clinically evident acute hepatitis worldwide. For hepatitis B, more than 8% can be found in Africa, Asia, Western Pacific Rim, 2 to 7% in Southern and Eastern Europe, and less than 2% in Western Europe, North America, and Australia. For hepatitis C, it affects approximately 170 million people worldwide and asymptomatic in 85% of the individuals. And then severe acute hepatitis is rare. For hepatitis B, 5% of the hepatitis B virus infected individuals go through hepatitis D. For the route of transmission, it's fecal oral for hepatitis A and parenteral for hepatitis B, hepatitis C, and hepatitis D. For the period of incubation, 2 to 6 weeks for hepatitis A, 2 to 26 weeks for both hepatitis B and hepatitis D, and 4 to 26 weeks for hepatitis C. The hepatitis A never has a tendency to form a chronic or carrier state, while for HBV it is 5 to 10%, more than 80% in HCV, and 10% in HDV, but 90 to 100% is for superinfection. For the serologic markers, we have anti-hepatitis A IgM for Hep A, HBsAg, anti-HBsAg, or anti-HB-Cap IgM for hepatitis B, and then here's for hepatitis C and for hepatitis D. Hepatitis C virus is a family Flaviviridae of genus Hepacivirus. It is a single-stranded RNA virus differentiated into at least 6 major genotypes. Chronic disease occurs in 80 to 90%, cirrhosis in 20% of chronic infections. 1 to 5% of HCV infections progresses to HCCA, and the fifth most common cause of cancer worldwide. HCV has a particularly effective immune evasion mechanism.
Nakamute si Faith.
Hello. For the pathophysiology, risk factors of HCV infection are displayed on the screen. Among these factors, people engaging in illicit intravenous drug abuse have the highest risk of HCV infection. Although rare, transfusion-associated infection has been the mode of transmission for our patient in the case, since he got a transfusion before the time when hepatitis screening was included in blood transfusion screenings. Also note that about a third of the cases have no identifiable risk factors. If these percentages are totaled, the listed risks exceed 100%. This is because patients may have multiple risk factors. About 90% of the patients with HCV infection progress into chronic disease. So with chronic infection also comes chronic inflammation. Repeated hepatic damage causes death to the hepatocytes and eventually fibrosis of the liver tissue. It is important to note that 1 in 5 patients having chronic HCV infection progress into cirrhosis, just like what happened in our patient. HCV leads to carcinoma in 1 to 5% of the affected patients. Next, please. So the typical clinical manifestations of patients with cirrhosis include ascites and jaundice. How do these manifestations develop? So in the cirrhotic liver, it causes portal hypertension since there will be an intrahepatic vasoconstriction and therefore high resistance to blood flow. And due to the blood vessels being compressed by the fibrotic tissue. So portal hypertension causes increased hydrostatic pressure in the veins and capillaries, which causes extravasation of fluid in the abdominal cavity. And in addition, the cirrhotic liver also has diminished protein synthetic function, leading to hypoalbuminemia, as what is being exhibited by our patient in the case. This also promotes movement of fluid from the lymphatics to the interstitium. And in cirrhosis, there is also decreased hepatic conjugation of bilirubin. This results to accumulation of bilirubin in the blood, manifesting as yellowish discoloration of the skin and sclerae, known as jaundice.
Okay, so for pathology of the liver associated with circulatory disturbances. So this disorder can be grouped according to whether the blood flow into the liver, through the liver, or from the liver is impaired. So for for occlusive disease of the portal vein or its major branches typically produce abdominal abdominal pain, and in most instances manifestation of the portal hypertension, principally esophageal varices that are prone to rupture. And then for the impaired blood flow through the liver, the most common intrahepatic cause of blood flow impairment is the cirrhosis. Then the physical occlusion of sinusoidal blood flow occurs in small group of diseases, which includes the sickle cell disease due to the obstruction of the sickle red cell, the DIC or the disseminated intravascular coagulation, which is due to the many small thrombi, the eclampsia, and the diffuse intrasinusoidal metastatic tumor, which is due to the physical obstruction by plugs of tumor, and sometimes with superimposed thrombosis. So all of these scenarios, the obstruction of the blood flow may lead to massive necrosis of hepatocyte and acute liver failure. And then next is the obstruction of the blood outflow. So the hepatic damage is the consequence of the increased intrahepatic blood pressure. Um, Hepatic vein thrombosis is associated with myeloproliferative neoplasm such as the polycythemia vera, inherited disorder of coagulation, antiphospholipid antibody syndrome, paroxysmal nocturnal hemoglobinuria, and the intra-abdominal cancers, particularly the hepatocellular carcinoma. So the obstruction of the blood flow include hepatic vein thrombosis or the Budd-Chiari syndrome and the sinusoidal obstruction syndrome, which is previously known as the veno-occlusive diseases. Next, please. So viral hepatitis may pursue several clinical courses. So this one is the acute symptomatic infection with recovery. Here, the patient is identified due to minimally elevated serum transaminases, or after recovery, there's a presence of the antiviral antibodies. So HAV and HBV infections can be subclinical events verified only by the presence of the anti-HAV or anti-HBV antibodies. And then the second is the acute symptomatic infection with recovery. In this can be divided into 4 phases: the incubation period, symptomatic pre-icteric phase, symptomatic icteric phase, and the convalescence. So there are different incubation period for different viruses. And then the peak infectivity occurs during the last asymptomatic days of the incubation period and the early days of the acute symptoms. Next, please. And the next is for the chronic hepatitis, which is defined as the symptomatic, biochemical, or serologic evidence of continuing or relapsing diseases for more than 6 months. So in some patients, persistent elevation of the serum transaminases may be only clinical evidence of chronicity. And then there's a prolongation of the prothrombin time, hyperglobulinemia, hyperbilirubinemia, and mild elevation in alkaline phosphatase level. There are also symptomatic for symptomatic individuals, the most common finding is fatigue. And then for the less common symptoms is the body malaise, loss of appetite, and occasional bouts of mild jaundice. Next is for the carrier state. So a carrier is an individual who harbors and can transmit an organism but has no symptoms. So there's two separate scenarios. The first is the individual who harbors the virus but have no liver disease, and the second is the individuals who harbor the virus and have asymptomatic non-progressive liver disease and non-progressive liver damage. So in these both case, particularly the second one, it is affected. The affected individuals constitute reservoir of the infection.
Role of immune response in causing acute liver damage in liver hepatitis. In hepatitis virus infection, liver injury is caused by immune-mediated mechanisms. Both virus-specific T cells and non-specific cells contribute to liver injuries, and uh, suppressor cells such as regulatory T cells and myeloid derivative suppressor cells control the immune-mediated liver cells. Multiple causes other than viral hepatitis in sublimate and fulminant of hepatitis failure, hepatic failure, encephalopathies. Second is Wilson's disease. Third is Budd-Chiari syndrome. Fourth is endogenous metabolic disorders. Laboratory tests. First, we can prescribe for sonography. Then
For the laboratory tests, we have sonography, serum aminotransferases, liver function tests, screening with enzyme immunoassays, confirmatory tests, including the recombinant immunoblot assays or the RIBA, which must be considered if EIA is positive, and these are more specific but less sensitive than EIAs. HCV RNA using polymerase chain reaction detects viral load. It is the gold standard for diagnosing hepatitis C virus. It detects virus as early as 1 to 2 weeks after infection. It is used to confirm active infection and to monitor patients on antiviral therapy to indicate a cure from HCV. So a positive RIBA and HCV RNA indicates active infection, and a positive RIBA and a negative HCV RNA indicates a cure from treatment. So your liver function tests include alanine aminotransferase, alkaline phosphatase, aspartate aminotransferase, albumin, bilirubin, both direct and indirect, prothrombin time, and partial thromboplastin time. Next slide, please. So serological tests used in differentiating between various forms of viral hepatitis includes, for hepatitis A, we have the anti-HAV IgM, which indicates active infection, the anti-Hepa A virus IgG, which indicates recovery from indication or vaccination, which is also an indicator of a protective antibody. For Hepa B virus, we have the hepatitis B surface antigen, which appears within 2 to 8 weeks after exposure. It is the first mark of infection. It persists up to 4 months in acute hepatitis, and longer than 6 months defines chronic hepatitis B virus. Hepatitis B E antigen and HBV DNA indicates ineffective particles, and it appears after the Hepa B surface antigen disappears. Then we have the anti-HBV core antibody IgM, which is a non-protective antibody and remains positive in acute infections. It persists during the window phase or the serologic gap. It also converts entirely into anti-HBC IgG by 6 months. And then we have the anti-HBV surface antibody, which are protective antibodies and markers of immunization after hepatitis B virus vaccination. For chronic hepatitis B virus, we have persistence of the surface antigen longer than 6 months. The anti-HBC IgM converts to anti-HBC IgG by 6 months. And these are for healthy chronic carriers. For the hepatitis D virus, we have the presence of the anti-HDV IgM or IgG, which indicates active infection. IgG is not a protective antibody. For hepatitis E virus, we have the presence of the anti-HEV IgM, which indicates active infection, and the anti-HEV IgG indicates the recovery or protective antibodies. So the table below shows the serologic studies in hepatitis D virus with the interpretation being earliest phase of the acute HBV, acute infection, window phase or serologic gap, results for recovered from the hepatitis B virus, results for immunized individuals, results for healthy carriers, and for infected carriers.
So for the treatment and management, we have regulated interferon plus ribavirin, sustained virologic response in 75 to 80% of patients with HCV genotype 2 or 3, and only 30 to 35% of patients with HCV genotype 1. So we have the first generation protease inhibitor drugs for HCV genotype 1. We have Teleprevir, Boceprevir in combination with interferon and ribavirin, which has 60 to 80% sustained virologic response rate. And it has a growing concern for viral resistance. Next. So we have the second generation HCV treatment for HCV genotype 1. We have the Sofosbuvir and HCV viral RNA polymerase inhibitor, Cimepravir and HCV protease inhibitor, up to 90% sustained virologic response. And for the management, we have orthotopic liver transplantation for end-stage liver damage, but with 50% chance of HCV reinfection, presumably from extrahepatic reservoir. So donor livers are also in short in supply.
Is this the last slide? Hello?
No, Doc, there is still
Okay.
a journal after this.
Okay, sige.
For the prognosis, response to treatment depends on the HCV genotype on the infected patient. Patients with genotype 1 and mutations in the IL-28B gene have generally poor prognosis, while patients having genotypes 2 and 3 HCV have the best response to the mentioned treatments.
For our journal, the title of our journal is Optimal Controlled Strategies for Preventing Hepatitis B Infection and Reducing Chronic Liver Cirrhosis Incidence. So it has been observed that the optimal vaccination and treatment are much more effective for reducing the number of exposed, infected, and liver cirrhotic individuals, and also to maximize the recovered individuals, and also to minimize the cost of the two measures. So since there are vaccination strategies available for hepatitis B infection, which ultimately leads to chronic liver disease, cirrhosis, so from the stimulations, it has been established that the optimal combination of vaccination and treatment is effective to control the disease progression. So eventually, liver cirrhosis is a significant cause of illness and death worldwide. It affects millions of patients all over the world. Liver cirrhosis occurs throughout the world irrespective of age, sex, region, and race. So to reduce the infections, hepatitis B virus vaccination should be started immediately after newborn birth. That is all for case 1, Doc.
Okay, so thank you so much. The diagnosis is for sure it's very clear no in the description that it's liver cirrhosis. But if you observe it in the case, you have two risk factors here. Number one, it's hepatitis C because of the history of the blood transfusion and proven by the presence of the antibody towards the HCV. Okay, can you see me? Okay. And second is the alcohol. Okay, alcoholic man siya. And as proven by the increase in the ALP and the GGT, no? As we know, if you had already your clean path, GGT is a marker of alcoholism, no? As well as biliary obstruction. Pero sa case mo it fits with the alcoholism. Okay, so for sure it's liver cirrhosis, but it is a toss between it can be both, no? Secondary to hepatitis C and or alcohol. Okay, question. Which hepatitis virus is the most common cause of hepatocellular carcinoma? Worldwide.
Is it Hep C, Doc?
Hep B. Hep B gyapon. Pero if the question is the most common Hep B, the most common cause of hepatocellular carcinoma among Caucasians, then it's Hep C.
Hep C.
But if it's all over the world, it's Hep B. Still Hep B. If it's if the question is the most common cause of hepatocellular carcinoma, the most common viral cause in Asians, then it's hepatitis B. Okay, so Asians hepatitis B, Caucasians hepatitis C, worldwide hepatitis B, still hepatitis B. Then what else? Ano raman? What would I like to correct pa? Can we go to the next slide? So, next slide. Okay. Cirrhosis. Okay. So dapat cirrhosis na siya. Cirrhosis secondary to hepatitis C infection. Question. Is the presence of anti-HCV indicative of recovery? Anti-HCV is the antibody produced by the person, right, being infected. But does it indicate recovery?
Not necessarily.
Not necessarily. Why?
Because it could indicate active infection or the body's response to an ongoing infection.
Okay, very good. Because in hepatitis C, you may have antibodies, no? But the virus will still be there. Okay? Compare it to hepatitis B, when when you have antibodies, the viral levels, for example, the surface antigen is already not detected. Now, if you look at the what they call this, the rise and fall of the viral markers in hepatitis B, the antibodies do not overlap with the antigen. Okay, but for hepatitis C, the antibodies overlap with the virus. So we cannot tell that it's a marker for immunity. Okay, question. Ano raman siguro? So some learning points, be able to know the significance of this liver enzymes, biliary epithelium enzymes, bilirubin. Okay, so I might ask, what's the pathophysio of the increase in direct bilirubin in this case? Okay, thank you so much. Let's go to the next group.
Thank you, Doc.
Okay.
So good morning, everyone. We are the group 2 and we are here to present case number 6. So for the history, SG is a 46-year-old white male with a history of chronic alcoholism and alcoholic cirrhosis. He was admitted to the hospital from the outpatient clinic with abdominal swelling and confusion. He has unintentionally gained 15 pounds during the past 4 weeks. According to his wife, the patient has not been sleeping well for several weeks, has been feeling very lethargic for the past 3 days, can't seem to remember appointments lately, and uncharacteristically has lost his temper with her several times in the last month. SG's boss at work had also telephoned her last week concerned about his unusual and violent behavior on the job. For the chief complaint provided by the wife, my husband's very the wife stated that my husband is very confused and he has been acting strangely. This morning, he couldn't answer my questions and seemed not to recognize me. I think that his stomach has been swelling up again too. He stopped drinking 4 days ago, but his cirrhosis seems to be getting worse. For the history, the patient is a 46-year-old male, which he is a chronic alcoholic and has alcoholic cirrhosis. He had a 15-pound gain in the past 4 weeks. He is unable to sleep well for the several weeks. He is lethargic for the past 3 days. He is unable to recall appointments. He easily loses his temper for the past month and has an unusual and violent behavior on the job. For the physical examination, generalities, the patient is restless, mildly jaundiced, and disoriented to time, place, and people. He is slow to answer questions, and his answers make little sense. He is ill appearing, but no obvious distress. For the vital signs, blood pressure is 120/75, pulse rate 83 and regular if in a supine position. For a standing position, his blood pressure is 118/70 millimeter per mercury and a pulse rate of 80 and is regular. Respiratory rate is 14 and unlabored. Temperature is 98.8 degrees Fahrenheit. His weight is 171 pounds. His height is 5 foot and 7 inches, and his SaO2 is 97%. For the laboratory results, hematocrit is 39.7%, which is decreased because the normal rate is 40 to 54%. His hemoglobin is 14 grams per deciliter, which is in normal range. Platelet is 34,500, which is decreased. For the liver enzymes, his AST is highly increased at 107 IU per liters. His ALT is also increased at 86 IU per liters. His albumin is decreased at 2.7 grams per deciliter. He has increased bilirubin. His HCV RNA is 2.8 million per ml. He is positive for the anti-HCV. He has prolonged PT and PTT. His ammonia is also increased at 250 UG per deciliter.
For the differential diagnosis, we rule in these three diseases were bacterial peritonitis, Wilson's disease, and hemochromatosis because they all presented jaundice, neurologic changes together with hepatosmegaly, with increased ALT and AST, and the presence of ascites. But the reason we rule these three out because they are all negative with the HEV RNA. Here are the picture of bacterial peritonitis, Wilson's disease. And for the final diagnosis, it is the liver cirrhosis with complication of grade 2 hepatic encephalopathy secondary to chronic hepatitis C infection.
For the basic of our diagnosis, so we based our diagnosis on three things, primarily on three things. That is from the history of the patient, the physical examination that was done to the patient, and the results that was obtained from the laboratory tests. We further subdivided the signs and symptoms that pertains to liver damage, or in this case, liver cirrhosis, hepatic encephalopathy, and hepatitis C infection. So the following signs and symptoms suggest that the patient has liver damage, like he had a history of chronic alcoholism and alcoholic cirrhosis. So we could say that the patient's cirrhosis could be decompensated. He also had an unintentional gained weight, which is 15 pounds. This is probably because of the accumulation of fluid in his abdomen. He is also mildly jaundiced and is positive with icteric sclera, so it means that there is an elevation of bilirubin in his blood. A spider nevi in chest and gynecomastia, so which means that the patient has hyperestrogenemia. A prominent veins observed around the umbilicus. So this pertains to caput medusae, which is a complication of portal hypertension caused by cirrhosis. So there is a distension or engorgement of the superficial epigastric veins. There are also several echymosis on lower extremities. He is also positive with hepatosplenomegaly. He has also increased serum ammonia levels, so we could say that the patient's liver function of detoxification is impaired. So there's an increase in serum ammonia levels, a decreased albumin levels because we know that the liver has a synthetic function of protein. So there are decreased albumin levels. His LFTs or liver function tests are also increased, which pertains to your cytosolic hepatocellular enzymes or AST and ALT, anemia and decreased platelet count. So maybe the platelets and the cells are also sequestered in the spleen because he is also positive with splenomegaly, and increased coagulation blood test because there is a decrease in the coagulation factors produced by the liver. Hepatic encephalopathy, the patient showed also signs and symptoms that pertains to hepatic encephalopathy, such as confusion. Um, he is not sleeping well. He is lethargic. He can't seem to remember appointments, slow to answer questions. He has lost his temper to his wife in a several months, and slight asterexis was also noted. So hepatic encephalopathy is a complication of liver cirrhosis, wherein there is an increased neurotoxic ammonia, and ammonia can easily pass through the blood-brain barrier and can cause neurotoxic effects. And for hepatitis C infection, the following signs and symptoms, we considered it as one, maybe that the patient has acquired hepatitis C infection because of the large cobra tattoo on the right upper arm, and also this one, the history of intravenous drug administration of heroin and intranasal cocaine. And also the gold standard, which really suggests that the patient has a hepatitis C infection, is that he showed seropositive anti-HCV and a quantitative PCR test of HCV RNA 2.8 million per ml, which suggests that he has a very high viral load. Next slide, please. So about 40% of individuals with cirrhosis are asymptomatic until the most advanced stages of the disease. So as I have mentioned a while ago, the patient is positive for gynecomastia and as well as the spider nevi on the chest. So this suggests that he has hyperestrogenemia. The four major clinical consequences of portal hypertension are ascites, formation of portal systemic venous shunts, congestive splenomegaly, and hepatic encephalopathy. The massive splenomegaly may secondarily induce hematologic abnormalities attributable to hypersplenism, such as thrombocytopenia or even pancytopenia. From the you can see on the screen at the right side. So here are the test category that you can evaluate that the patient has liver disease. So as I have mentioned a while ago, the patient's hepatocyte synthetic function, hepatocyte metabolism, as well as the detoxification function of the liver is impaired. Next slide, please. So here is also a diagrammatic representation of the stages of liver disease and other causes of cirrhosis. Next slide, please. And here is an algorithm showing how to diagnose a patient with cirrhosis. So as I have mentioned earlier, our diagnosis was based on the history of the patient, the physical examination that was done, the laboratory studies, and radiographic studies. So upon obtaining these tests, if you want to be sure or to determine the etiology of the cirrhosis of the patient, obtain abdominal ultrasonography with Doppler, and if not been already performed, to evaluate for morphologic abnormalities consistent with cirrhosis and to assess also for potential complications like ascites, varices, portal hypertension, portal vein thrombosis. And also, if possible, since the gold standard here for cirrhosis for diagnosing cirrhosis is liver biopsy. So this is also possible for the determination of the etiology via histology. Next slide, please. So here is a definition of hepatic encephalopathy. So it is a spectrum of disturbances in consciousness ranging from subtle behavioral abnormalities to marked confusion and stupor to deep coma and death. So it may progress over days, weeks, or months following acute injury. This is associated also with fluctuating neurologic signs, including rigidity and hyperplasia. So in this case, our patient showed a mild asterexis. So this is regarded as a disorder of neurotransmission in the CNS and the neuromuscular system. The elevated ammonia levels in the blood and the central nervous system correlate with the impaired neuronal function and cerebral edema. Next slide, please. So, a while ago in the laboratory test, it can be seen that the patient has a very high viral load. It is more than 800,000 international units per ml. Chronic hep C infection diagnosis is confirmed by detecting anti-HCV in serum and may lead to cirrhosis in more than or equal to 20% of cases after 20 years. In more than 90% of individuals with chronic hep C infection, circulating HCV RNA still persists despite the presence of your antibodies. Hence, in persons with chronic hep C, HCV RNA testing must be performed to assess the viral replication and to confirm also the diagnosis of a hep C infection. A clinical feature that is quite characteristic of chronic hep C is that there is a persistent elevation in the LFT or in the serum aminotransferases. Next slide, please. So here is a diagrammatic representation of the morphologic feature of acute and chronic hepatitis. So you can note that there is only a scant mononuclear infiltrate in acute hepatitis, but in chronic hepatitis, there is a dense mononuclear infiltrate, as well as there is fibrosis in chronic hepatitis, impairing the function of the liver. Next. And here is a histologic picture showing chronic viral hepatitis due to hepatitis C, showing characteristic portal tract expansion by a lymphoid follicle at the right side, figure 1816. Next slide, please. Guide question number 2. So identify a minimum of 15 clinical signs and symptoms that are consistent with the diagnosis of cirrhosis. So I've differentiated the signs and symptoms because signs refers to the manifestation that the doctor sees to the patient, and clinical symptoms refers to the manifestation that the patient is experiencing. So the clinical signs are the following: gynecomastia, fetor hepaticus, which means that there is a decreased hepatic demethylation. So there is a defect in the hepatocyte metabolism. Spider angioma, asterexis, jaundice, ascites, capitmedusis, sclerodermatous, hematemesis, tarry stool, hepatosplenomegaly, and hepatic encephalopathy. The clinical symptoms include nausea, vomiting, loss of appetite, confusion, itchy skin, which is caused by an increase in bilirubin, fatigue, hemorrhoids, dull abdominal pain, peripheral edema, and anemia. Next slide, please.
So I'll be discussing the complication of liver cirrhosis. First is the high blood pressure at the veins that supply the liver, that's portal hypertension. Cirrhosis slows the total flow of blood through the liver, thus increasing the pressure in the vein that brings blood to the liver from the intestine and spleen. Second, the swelling in the legs and abdomen. The increased pressure in the portal vein can cause fluid to accumulate in the leg as edema and in the abdomen as ascites. So edema and ascites may result from the inability of the liver to make enough certain blood proteins such as albumin. Next is the enlargement of spleen, splenomegaly. Portal hypertension can also cause change due to swelling of the spleen and trapping of white blood cell and platelets. Decreased white blood cells and platelets in the blood can be the first sign of cirrhosis. Bleeding. Portal hypertension can cause blood to be redirected to smaller veins drained by the extra pressure. These smaller veins can burst, causing serious bleeding. Portal hypertension may cause enlarged veins like varices in the esophagus, esophageal varices, or in the stomach like gastric varices, and lead to life-threatening bleeding. If the liver can't make enough clotting factor, this also can contribute to continued bleeding. Next, in the infection, the cirrhosis in our body have difficult fighting infections, so the ascites can lead to bacterial peritonitis, a serious infection, malnutrition. Cirrhosis can also make it more difficult for our body to process nutrients, leading to weakness and weight loss. Next is the buildup of toxin in the brain, the hepatic encephalopathy. Liver damage by cirrhosis is not able to clear the toxin from the blood as well as a healthy liver can. This toxin can then build up in the brain and cause mental confusion and difficult concentrating. With time, hepatic encephalopathy can progress to unresponsiveness or coma. Next is jaundice. It occurs when the diseased liver cannot remove enough bilirubin, a blood waste product, from the blood. It causes the yellowing of skin and eyes and darkening of urine. Bone disease. Cirrhosis can also loses the bone strength and it is at greater risk for people to cause fracture. And the next is the increased risk of liver cancer. A large portion of people who develop liver cancer have pre-existing liver cirrhosis. And then last is acute on chronic cirrhosis because it can also end up experiencing multi-organ failure. Next slide. So the guide question number 1. Hematemesis and the Terry stools are clinical signs of which serious potential complication of cirrhosis. Hematemesis and Terry stools are indicative of gastrointestinal bleeding, which can be complications of cirrhosis. Portal hypertension is another serious complication of cirrhosis, which can also cause esophageal bleeding, resulting to the hematemesis and Terry stool. Next slide.
Guide question number 4. Which single laboratory test strongly suggests that the patient has developed hepatic encephalopathy? So the ammonia blood test can strongly suggest that the patient has developed hepatic encephalopathy because a while ago it was shown that the result of his ammonia is way high, which is 250 microgram per DL. Next slide, please. So here is a table showing how to grade hepatic encephalopathy in a patient with liver cirrhosis. So this is called your West Haven criteria. So ammonia has multiple neurotoxic effects. Again, hepatic encephalopathy is a disorder of astrocyte function, and the toxic accumulation of glutamine in astrocytes will lead to its swelling and ultimately cell death, which will inhibit the generation of excitatory and inhibitory postsynaptic potentials in which our patient showed multiple neurotoxic effects. So grade 1 is said to be covert, and patients with grades 2 through 4 hepatic encephalopathy are said to be overt. In this case, our patient showed a grade 2 grading according to West Haven criteria because he is lethargic, he has behavioral changes, time disorientation, asterexis, personality changes, and hypoactive, deep DTRs or deep tendon reflex. So this criteria is the most frequently used criteria for grading hepatic encephalopathy. encephalopathy. Next slide, please.
For guide question number 5, does the patient have any signs of dehydration or hepatorenal syndrome? So our answer is yes. People with hepatorenal syndrome have a variety of signs and symptoms related to advanced liver diseases such as jaundice, ascites, abdominal pain, malaise, swollen breast tissues, weight gain, confusion and/or memory loss related to hepatic encephalopathy. So in this case, Mr. SG has a slightly decreased potassium level, which may be due to kidney dysfunction. Next slide, please. So hepatorenal syndrome, or HRS, is a life-threatening condition that affects kidney function in people with acute liver failure or advanced liver disease. So there are two types of HRS, the type 1 and the type 2. HRS type 1 is associated with rapid kidney failure and an overproduction of creatinine. So individuals with this type are more likely to suffer from hepatic encephalopathy. For the type 2, it is associated with gradual kidney damage and causes renal dysfunction that generally progresses much slower than it does in type 1. So affected individuals of this type are less likely to develop jaundice and usually do not develop hepatic encephalopathy. So the treatment for HRS is liver transplantation. However, not all patients are eligible for transplant. So other options include medications to help improve blood volume and redirect blood back towards the kidneys, and also renal replacement therapy or hemodialysis. Next slide, please. So for guide question number 6, so the patient's primary care provider has decided to conduct extensive clinical studies for the diagnosis of liver cancer. So which single abnormal laboratory value has raised a concern that hepatocellular carcinoma may have developed? So an increase of level of alpha fetoprotein AFP is a single abnormal laboratory value which can be used towards the diagnosis of hepatocellular carcinoma. So AFP is measured in nanograms per milliliter, and AFP level between 10 to 20 ng per ml is normal for adults. Next, please. So elevated AFP levels could be a sign of cirrhosis or chronic acute hepatitis. So an extremely high level of AFP in your blood, which is greater than 400 ng per ml, could be a sign of liver tumors. So high levels of AFP could also mean other cancers, including Hodgkin disease, lymphoma, and renal cell carcinoma or the kidney cancer.
Next, we have pathophysiology. So we have cirrhosis due to your hepatitis C virus. So your cirrhosis could lead to liver failure or portal hypertension. So in your liver failure, it leads to the destruction of your hepatocellular integrity and also a decrease in your liver function. Since the integrity is destroyed, the cell spills the AST and ALT in the blood, which results in increased levels of your AST and ALT. For your decreased liver function, there will be a decrease in biliary excretory function, which leads to an impaired bilirubin conjugation and an accumulation of unconjugated bilirubin, which would result to jaundice. We also have a decrease in synthetic function, both in your clotting factors and your plasma protein synthesis, which results to an elevated prothrombin time and hypoalbuminemia. Next would be a decrease in metabolic function, so decrease in blood detoxification, ammonia accumulation in blood, which would lead to hepatic encephalopathy, which manifests into your asterexis. So in your portal hypertension, this would stimulate the endothelial cells to release your LO, so which will lead to a decrease in BP, which in turn is compensated by your RAAS. So there will be an increased perfusion pressure in your interstitial capillaries, which would lead to the leaking out of fluid from the tissue towards the peritoneal cavity. Both this and hypoalbuminemia would result to ascites, eventually would result to a prominent abdominal distension. We also have a reverse of blood flow from portal to systemic circulation due to your portal hypertension. So this would result to an opening of the portosystemic shunt, then your venous bypasses in the falciform ligament of the liver, which would result to your caput medusa. Next slide, please.
For treatment, we all know that this case has an acute hepatitis C virus infection. So we would be giving your pegylated interferon alpha plus your ribavirin. So your pegylated interferon alpha activates your JK STAT pathway, thereby activating the various non-specific resistance to the viral infection. While your ribavirin, this inhibits the activity of the enzyme RNA-dependent RNA polymerase. Due to its resemblance to the building blocks of your RNA molecules, this thereby inhibiting viral RNA synthesis. So also, aside from your pegylated interferon alpha and your ribavirin, direct acting oral agent that was also discussed by the previous case will also be given to this patient. So these are the following: your sofosbuvir, ladipasvir, velpatasvir, rotanivir boosted with your paritasvir, your ombitasvir, dasabavir, elbasvir, crozabprivir, daclatasvir, and simiprivir. Next slide, please. For the management, since the patient is on hepatic encephalopathy, and as we all know that your hepatic encephalopathy is a complication of your ammonia accumulation in the blood due to your liver failure. So we will be giving hydration to your patient as well as your fluid electrolyte imbalance corrections. The diet will also be limited to the 35 to 40 kcal per kilogram per day, and as much as possible, a vegetable protein source should be used rather than your animal protein. We will also be administering your lactulose, a non-absorbable disaccharide, which results in your colonic acidification and elimination of your nitrogenous product through the gut. So your lactulose promotes 2 to 3 soft stools per day, and if there is a um, poorly response to your lactulose alone, a poorly absorbed antibiotics are often used as an adjunctive therapies for patients who have difficult time with your lactulose. Next slide, please. Aside from that, we could also administer neomycin and metronidazole, which has been used in the past to reduce the individual side effects of itch, and neomycin is for your renal insufficiency and ototoxicity, and metronidazole for your peripheral neuropathy. As administration of your rifaximin 550 milligram BID, and in some journals on treatment on management of a hepatic encephalopathy, zinc supplementation is recommended. Next slide.
Okay, for the prognosis, the Child-Turcotte-Pugh scoring system will be used to predict the mortality of the patient. Now, parameters included in this Child-Pugh scoring system are serum bilirubin, serum albumin, PT prolongation, hepatic encephalopathy, and ascites. Now, for the first parameter, we have the serum bilirubin. So the patient has a serum bilirubin of 2.4, so which gives it a score of 2. Second parameter is the serum albumin. The patient has a 2.7 serum albumin, so that is under the score of 3. Now for the prothrombin time prolongation is around 3.6 seconds. Now this is under the score of 1. So for the hepatic encephalopathy, so the patient's history shows a moderate to severe, so this should be moderate, not minimal. So which is under the score of 3, moderate to severe. So next is ascites. So the patient's wife mentioned that his stomach has been swelling up lately and a 15-pound weight gain. So this also indicates a slight to moderate ascites. So this is also score of 3, so this is moderate, not slight. So bringing to a CTP total score of 12. Now a score of 12 is under the class C, which has a 1-year survival percentage of 45% and a 2-year survival percent of 35%. So in conclusion, the prognosis of the patient is poor. Next slide, please. The patient's cirrhosis showed a sudden unexpected progression due to the presence of an ongoing infection, so specifically hepatitis C. So as shown here in the laboratory test results, there is a presence of antibody for HEV and a viral load of around 2.8 million, so which led to the worsening of the patient's condition. Next.
That's all. Thank you.
Okay, very good, no? For the second group, it was exhaustively explained, no? So yeah, I don't know what to say. Okay. Kanang you have really repeated already, no? Time and time again about the pathophysiology of cirrhosis, what are the complications, etc. And thank you very much. No, I don't think I have to add anything. Okay, very much. This case is very much similar to the first one, no? Alcoholic, then hepatitis C. Okay, and then cirrhosis. What's really clear is the cirrhosis. Okay, so let's go to the next group. Very good. Group two.
Thank you, Doc.
Okay.
Good morning, Doc.
Good morning.
Saan siya? Kadali lang daw ako, sorry. Share screen. Makita ang slide, everyone?
Yes.
Okay. Good morning, Doc, again, and good morning, everyone. So we are group number 4, and our case is case number 8. So for the case in salient feature, the chief complaint of the patient is usually verbatim, stating, "I don't really feel seriously sick, but my wife insisted that something is wrong and that I should see a doctor. I've been a bit tired and weak now for nearly 3 weeks. I've not been working more than usual. My appetite is good, and I'm only 52, so it can't be old age setting in already. Also, this may be nothing, but I'm a little sore under my right rib cage. Not really pain, but it is uncomfortable when I jog." For the patient history, the patient again is a 52-year-old. Sorry. Uh, Hi there. The patient is a 52-year-old white male, and then the history of present illness: 3 weeks prior to consult, patient was experiencing fatigue and body malaise. The past medical history: the patient was involved in a multiple vehicular accident requiring blood transfusion and had cholecystitis 7 years ago. And for the surgical history, patient had cholecystectomy 7 years ago. And for the family history, there is no known history of liver disease. Mother was alcoholic but died due to a car accident. The father has type 2 diabetes. And for the personal history of the patient, there is no noted international travel, and the patient stated that he exercises daily. For the social history, the patient is a tobacco smoker and drinks 6 pack of beer on weekends. There's also a minimal consumption of caffeine and a history of IV drug use and cocaine snorting as a young adult, which mentioned he was clean for 15 days. And there's also no history of an unprotected sex or living with anyone diagnosed with viral hepatitis. For the drug history, there's no medication taken and no known food and drug allergies. For the review of the system, there are only two positives noted: progressive fatigue and weakness, and positive for elevated liver enzyme. For the physical examination, the patient is a well-developed, well-nourished, muscular white male, and no abnormalities detected. So all vital signs are normal, within normal. For the physical examination, um, the only noted for the PE of the patient is mild scoliosis, and there is a positive bowel sound, which is usually an intestinal hypersensitivity, and the rest is within normal also. For the final diagnosis,
Final diagnosis.
So the final diagnosis is cirrhosis secondary to chronic viral hepatitis C. So the basis is physical symptoms, fatigue and malaise, which is a clinical manifestation of a patient with hepatitis C. History: drink 6 packs of beer on weekends, possible contributory factor of the patient having cirrhosis. Second is the history of IV drug use and cocaine snorting. Based on the CDC, there are at least 60% of patients with hepatitis C have a history of being injecting drug users. In the laboratory test, in the serology testing, it has a result of positive of IgG anti-HCV antibody and HCV RNA indicating of hepatitis C virus. Next is the urinalysis, which is there is a presence of bilirubin in the urine indicating that there is a progressive liver injury. Next. So liver biopsy. So the result in the liver biopsy says na lymphocyte aggregates and some macrophages within portal tracts, mild periportal fibrosis, microvesicular steatosis. So in the table, it states that mild periportal fibrosis is a stage 1 chronic cirrhosis. And the last is all pathologic findings consistent with chronic hepatitis. This is the reason why our group come up with cirrhosis secondary to chronic viral hepatitis C.
Hello, so differential diagnosis. So our differentials based off of our review of systems and what the patient said, we have alpha-1 antitrypsin deficiency, autoimmune hepatitis, liver abscess, and acute hepatitis C. So for alpha-1 antitrypsin, our rule-in would be fatigue, onset chronic hepatitis with extrapulmonary manifestations, but we have no X-ray showing emphysema, so rule out. Autoimmune hepatitis, fatigue, but may be asymptomatic with elevated liver enzymes or liver function tests. And to rule out, we have no ANA, no hypergammaglobulinemia, because autoimmune hepatitis, also known as leukoid hepatitis, we don't have tests for those or results. So for liver abscess, you have your right upper quadrant pain, but there is no fever, so rule out. With acute hepatitis C, we have our anti-HCV IgG, but the biopsy actually is consistent with a stage 1 chronic hepatitis with a mild periportal fibrosis. So that is our differentials. Okay, so why is the patient's WBC differential consistent with diagnosis of viral hepatitis? Oftentimes, patients with viral hepatitis have normal or unremarkable WBC differential counts as seen in the patient. So if you look at it, it's not like the perfect normal picture if you see the differentials, but everything is within the normal range. Even the WBC count, which was a 9.9, 10 to the third 2 millimeters cubed, that is depending on the hospital you're in, on the upper end of a normal range. So because the CBC may vary with chronic viral hepatitis, we don't see anything that wild in the diff count. Okay.
And for our pathophysiology, next slide, please. So first, I'm going to discuss how the virus replicate and then affect the hepatocyte. First, the 7-step of viral life cycle indicate in the white boxes. Firstly is the attachment. The viral particle surrounded with lipoprotein binds the target cell by interacting with several receptor, most of which are shown here in the figure, considered essential, and others are accessory. Next is your entry. Following attachment, the virus enters through the Catherine mediated through your endocytosis. Next is uncoating. the cellular and the viral membrane fuses and the capsid is disorganized with the process triggered by a low pH of endosome. After uncoating, the positive strand of RNA genome is released into the cytoplasm. Next is your translation. The genomic RNA is directly translated in the polyprotein precursor that is then cleaved into single proteins by both host and the viral protease. Next is your replication. The non-structural protein and some of the host factor form a replication complex that synthesizes multiple copies of HCV RNA genome via a minus-strand replicative intermediate. Assembly and your maturation. Packaging of your viral progeny takes place in the endoplasmic reticulum, from which the virion requires the envelope of your E1 and E2 glycoproteins. Maturation and association with endogenous lipoproteins to form a lipoviral particle immediately following. The release, and lastly, the release of virions are released from the cell mostly by exocytosis or transmitted to other cell via your cell-free mechanism. Next slide, please. So here, if the virus tend to target the cell of the liver, and when they get in and infect the cell, they tend to present an abnormal protein such as your MHC1 shown here in the figure. At the same time, you got your immune cell infiltrating the liver, trying to figure out what is going on. So your CD8 T cell will recognize this abnormal protein. And then the hepatocyte then undergoes cytotoxic killing and cell apoptosis. Next slide, please. So the hepatocyte that undergo apoptosis is called Cancelman body, or typically takes place in the portal tracts and lobules in the liver. The cytotoxic killing is the main mechanism behind inflammation of the liver and eventually liver damage in viral hepatitis. Next slide, please. So hepatitis C again, this do not cause apoptosis of the hepatocyte directly. Instead, they activate the immune system within the liver, leading to inflammation response, which cause the damage and cell death. In some people, will clear the virus and would only have an acute cause, and in some people, will progress into chronic infection due to recurrent cycles of inflammation, damage, and wound healing that over time leads to scarring and fibrosis. So mechanism in which hepatitis C becomes chronic is due to downregulation of viruses, specific T cell response, your CD4 and CD8, and next is damage comes from secondary mononuclear recruitment. Next slide, please. So here is a summary of the pathogenesis with the clinical findings at the site. So first, the infection with the virus that targets the liver, your hepatitis C virus. Then the hepatocyte are invaded and damaged. Then foreign particles and tissue damage activate by immune system that would lead into liver inflammation. Then lysis of or bursting of hepatocyte. Then some patient will progress into acute infection that will resolve over time and symptoms above will normalize. And some people will progress into chronic viruses that persist over time and additional symptoms may develop such as decreased hepatic metabolic activity, decreased synthesis of plasma protein, and decreased bilirubin clearance from blood. Bilirubin end up under the skin. Then will progress or your liver will progress and deteriorate into cirrhosis. Next slide, please. Why is a previous blood transfusion not likely cause a viral hepatitis? Blood products are tested for hepatitis B and C, so it is not likely that a person will get hepatitis. So it is rare to have a hepatitis C since blood screening is introduced since in 1992. So hemovigilance programs such as are presently being installed will provide more data on safety of blood transfusion. Introduction of HCV nucleic amplification such as your NOT as quality control of manufacturing pools for plasma products or as form of blood donor screening by mini-pools is anticipated. Given industrial development, not testing of individual blood donation, HCV not testing will further annihilate the residual risk, and cost effectiveness will become relatively low in comparison with public health measure. Next slide, please. So here is a screening methods that from the World Health Organization. So your screening markers such as your anti-HCV, HCV antigen, and HCV RNA. Next.
Okay, for the diagnostic modalities, the diagnostic tests for the hepatitis C include the serologic assays that measure human antibodies generated in response to HCV infection and molecular virologic assays that directly detect the HCV RNA. So first, the HCV antibody test is the most frequently used antibody test to initially screen for the HCV infection. The test is performed by the enzyme immunoassays, which detect the presence of hepatitis C antibodies in serum. The result of the test is reported as positive or negative. Number two, the presence of the HCV RNA is required to confirm chronic HCV infection. Therefore, a positive HCV antibody screening result must be followed by a test for the HCV RNA. It detects and measures the viral hepatitis C RNA in the blood. It is also used to monitor a patient's response to therapy or treatment. The presence of the viral RNA indicates an active viral infection. It can be acute or chronic hepatitis C virus, but up to 85% of people who have hepatitis C will eventually develop the chronic form of the disease, and cirrhosis eventually occurs. Third, next please. Recombinant immunoblock assay, or RIBA, is a highly specific test that in the past was used also as a confirmatory test of antibody result. It still required HCV RNA testing for the diagnosis of chronic infection, but this test is no longer in use or available in the United States. Okay, here the table, it shows the interpretation of the patterns of the HCV markers. Okay, here is the summary. For screening for antibodies against the virus is the frontline technique for detecting a past or current hepatitis C virus infection. So for most individuals, the test remains positive throughout their life even after the disease has been cured. But a positive result does not mean the person is protected against a new infection. So to diagnose active hepatitis C in an individual with a positive result, an HCV RNA test must be completed. The presence of viral, okay. Next. Okay, next. Okay, so why were the serum concentrations of vitamin A, D, and E tested? Vitamin A deficiency is associated with hepatitis C virus chronic infection and with unresponsiveness to interferon-based antiviral therapy. A high percentage of patients with chronic HCV infection have serum vitamin A deficiency. Vitamin D deficiency is involved in the pathogenesis of chronic liver diseases caused by the hepatitis B and C viruses, and high prevalence of vitamin D deficiency with serum levels below 20 mg per ml in patients with HBV and HCV infections are found worldwide. Why were the serum concentrations of vitamin A? Okay, next. So what is the most significant abnormal findings in the patient's urine, and why is this finding consistent with the patient's condition? The presence of the bilirubin. When the hepatitis infection causes the liver to be inflamed, the liver can't easily process bilirubin, which leads up to a buildup of it in the blood and excreted in the urine.
Okay, so for treatment, um, so according to Harrison's, currently hepatitis C vaccination is not feasible practically. So therefore, combination drug therapy has been proven to be remarkably effective. So we have your interferon, IFN, has been the drug of choice for the treatment of hepatitis C and used in combination with another drug, ribavirin. IFN-based therapy results in a sustained virologic response CVR can improve the natural history of chronic hepatitis C and may reduce the risk of HCC in patients with HCV-induced cirrhosis. So the goal of current treatment is to eradicate HCV RNA, which is defined by the absence of detectable HCV RNA in the blood 6 months after treatment is stopped and is associated with a high probability of cure. That would be all.
For the management, upon diagnosis of an HCV infection, patients require counseling and certain clinical interventions prior to initiation of antiviral therapy. Prevention of further liver damage is crucial, and so patients should also be counseled in prevention of HCV transmission, such as avoid sharing toothbrush, dental shaving equipment, and cover bleeding wound to prevent possibly coming in contact with the blood. Patients should also be counseled, should be advised not to donate blood, and patients should also avoid alcohol. Next, please. Why is it critical that this patient should refrain from further use of alcohol? Because it hastens the progression of liver damage, causing liver failure and eventually causing liver cancer. And secondly, it will impede responses of the treatment, causing complications and delaying of the endpoint of the treatment. That is all.
So for prognosis, next please. The prognosis vary on what stage the patient is. On early stages, it has a good prognosis because if liver cirrhosis is diagnosed early and the cause is treated, further damage can be limited and rarely reversed. In its advanced stage, cirrhosis is usually irreversible, so treatment may already involve liver transplant. And about 5 to 20% of people with chronic hepatitis C will develop cirrhosis. With that in mind, it takes about 20 to 30 years for cirrhosis to develop in that population. That's all. Thank you.
For the journal, it's early virus clearance and delayed antibody response in the case of coronavirus disease 2019 with a history of co-infection with human immunodeficiency virus type 1 and hepatitis C virus. So, according to the journal, the patient had a travel history to Wuhan, the epicenter of COVID-19, and displayed the clinical presentation of COVID-19 such as fever and typical pneumonia on CT. Through the SARS-CoV-2 RNA test, though the SARS-CoV-2 RNA test was persistently negative on different specimen samplings at various times, plasma anti-SARS-CoV-2 antibody was positive, which together with a typical clinical presentation which confirmed the diagnosis of SARS-CoV-2 infection. The reasons underlying the undetectable RNA of SARS-CoV-2 in this case are unclear, but one potential explanation is that he was taking anti-HIV-1 agents that have been reported to have anti-SARS-CoV-2 effects, and his close contact partner with HIV-1 infection, who was also taking anti-HIV agents, also tested negative for SARS-CoV-2 RNA. These data are consistent with the notion that some anti-HIV-1 agents may have preventive and or therapeutic effects and against SARS-CoV-2. And another possibility is that the activated type 1 interferon may help suppress SARS-CoV-2 because a previous study has shown that HIV-1 infection may induce high levels of type 1 interferon, which may to some extent clear SARS-CoV-2 infection, thus leading to persistently undetectable RNA. Notably, the SARS-CoV-2 specific total antibody titer was low and the IgM was high even after 42 days of illness, which was significantly different from antibody levels in other patients who have recovered from the disease at similar time points of the illness. And importantly, the total antibody level was largely increased and IgM remained at the peak level 1 week later, suggesting that the antibody responses against SARS-CoV-2 in this HIV-1 infected case were delayed. It is possible that there was early incomplete clearance of the virus that induced a subsequently delayed antibody response. Future studies are still needed to address this mechanism underlying the delayed antibody response to SARS-CoV-2 with a history of co-infection with HIV-1 and HCV. Even with the latter being cleared in this case, even with the latter being cleared in this case. In summary, we report for the first time a case of COVID-19 in a patient with a history of co-infection of HIV-1 and HCV who showed delayed antibody response. This case highlights the possible influence of HIV-1 induced immune dysfunction on the immune responses to the clearance of SARS-CoV-2.
Okay, so that ends our case, though. Thank you.
Okay. Yeah, syempre, no, when the patient has HIV, the the production of antibodies is very is affected. It's very slow. Okay, I think that explains also the ano. Pero naluoy na lang, no, kay naluoy na lang. Maybe God just pity the patient because he has already HIV and Hep C. Then early virus clearance na lang. Okay. Anyway, question. There was this question about why was the uh, why was the level of vitamin A, D, and E taken? Okay. So I think the answer to that is balik kita. The answer to that is the vitamin A, D, and E are fat soluble vitamins, and sorry, and when in cirrhosis you have impaired conjugation, impaired transport of conjugated bilirubin. The conjugated bilirubin stays in the liver, okay, and the patient becomes jaundice, okay. So this conjugated bilirubin is needed in the bile for absorption of these fat soluble vitamins. Okay, so that's why. So for example, if the level of ADE are low, so it is an index of the low production of conjugated bilirubin in the form of bile. And ang next kay the bilirubin, the presence of bilirubin in the urine. I think this is the slide after this. Yeah, the present single most important abnormal finding in the patient's urine. So it's the bilirubin, and what type of bilirubin is expected to be seen in the urine? Conjugated or unconjugated?
Conjugated, no?
Yeah, conjugated siya. Conjugated bilirubin. Because the bilirubin, what's the explanation for that? It's a conjugated, di ba? In the normal bilirubin metabolism, when the conjugated bilirubin is excreted in the gut, it becomes deconjugated again by some bacteria. Okay, and when it is urinated, it's in the form of urobilin. Okay, so whenever you see bilirubin, it's in uh, the exact form of katog yung bilirubin yun, that is conjugated. Let's go back to the bilirubin metabolism ba. So ana lang siya. Okay, so next, I think, so it's still Hep C, no? So we have lots of cases of Hep C and cirrhosis. Okay, so next group, thank you.
Thank you, Doc.
Okay.
So good morning, Doc. Good morning, everyone. We are Group 5 from Section A, and we're going to present about case number 10. So a 58-year-old female with treated hypertension as her only other medical history presents to her general practitioner with constant right upper quadrant pain and nausea after a particularly rich celebratory meal. She describes previous similar episodes after meals, but she attributed this to indigestion from overeating. On questioning, she has not noticed skin or conjunctival discoloration. Abdominal examination is unremarkable, and full blood count, urea and electrolytes, and liver function tests are all normal. So patient medical history, our patient is 58 years old, female, with no known allergies and past medical history hypertension. Salient features, right upper quadrant pain and nausea after a celebratory meal, no skin discoloration and no conjunctival discoloration as well, and unremarkable abdominal exam and laboratory tests are normal.
So differential diagnosis. Next, please. So we have acute hepatitis, acute pancreatitis, and peptic ulcer disease. So age preference for hepatitis A are children and young adults. Hepatitis B, young adults, babies, and toddlers. Hepatitis C, any age, more common in the adults. Hepatitis D, any age, and hepatitis E virus in young adults from 20 to 40 and older adults above 60. So acute hepatitis is more common in men. And there is right upper quadrant pain, nausea, and skin or conjunctival discoloration. Stool is pale and the AST and ALT levels are elevated. For acute pancreatitis, the peak age of incidence occurs in the 5th and 6th decades, and it is more common in men. Most often, the pain is located in the epigastric region, and stool is pale yellow, greasy, and foul-smelling. Serum bilirubin, ALP, and ALT can be transiently elevated. For peptic ulcer disease, the duodenal ulcer usually appear between 30 to 50 and stomach ulcer after the age 60. So duodenal ulcer is more common in men while stomach ulcer is more common in women. So pain is located in the epigastric region and there is no skin or conjunctival discoloration and stool is black or tarry. Next, please.
Our final diagnosis is acute cholecystitis, probably secondary to cholelithiasis. So to define these terms, cholelithiasis is the formation of gallstones, while acute cholecystitis is the inflammation in the gallbladder, usually due to accumulation of bile trapped in the bladder because of gallstone obstruction in the cystic duct. So symptoms include previous episodes of right upper quadrant pain lasting more than 6 hours and the absence of jaundice. So our basis of diagnosis is that our patient experience epigastric or right upper quadrant pain occurring shortly and nausea after protein or fat-rich meals on more than one occasions, and no skin or conjunctival discoloration was noted. The incidence increases with age, which is greater than 40 years old, and it is 2 to 3 times more frequent in women than in men.
So for guide question number 1, what is the likely cause of her symptoms? So acute cholecystitis often begins as an attack of biliary pain that progressively worsens. This biliary pain or biliary colic is a constant and often long-lasting pain that is usually caused by gallstones, producing inflammation or obstruction. And it usually follows a fatty meal. So if there is an excess of cholesterol in relation to phospholipids and bile acids, unstable cholesterol-rich vesicles remain, which aggregate into large multilamellar vesicles that precipitate into cholesterol crystals. When these crystals are forced against the gallbladder outlet, they can obstruct the cystic duct or the common bile duct, resulting to increased intraluminal pressure and distension of the viscus. And this cannot be relieved by repetitive biliary contractions because the gallbladder does not contract in peristaltic waves. Rather, each wave is several hours apart. So the resultant visceral pain is characteristically a severe, steady ache or fullness in the epigastrium or right upper quadrant of the abdomen, with frequent radiation to the interscapular area, right scapula, or the shoulder. However, as the episode progresses, the pain of acute cholecystitis becomes more generalized in the right upper abdomen that is prolonged and lasts usually more than 6 hours. And the patient is also experiencing nausea and vomiting, which frequently accompany the episodes of biliary pain.
For guide question 3, what complications are associated with this condition? So most patients are asymptomatic with cholelithiasis, but there is a 1 to 4% annual risk of developing symptoms or complications. Acute cholecystitis is presented as repeated episodes of biliary colic that results in inflammation of the gallbladder, sometimes with bacterial infection. It is also characterized by the presence of fever, systemic malaise, raised inflammatory markers, and peritoneal irritation. Complications will depend on the size of the stones. With smaller stones, they can escape into the common bile duct where they may lodge in the narrowing of the hepatopancreatic sphincter or the sphincter of Oddi, where they can obstruct the common bile duct and pancreatic duct, causing obstructive jaundice and pancreatitis respectively. With large stones in the gallbladder, they can compress the common bile duct indirectly, causing obstructive jaundice in a condition called Meritzi syndrome. So, rare complications involved include erosion of gallstones into the duodenum or stomach, causing a fistula and gallstone ileus, where escaped gallstones obstruct the small bowel distally.
So for the pathophysiology, since acute calculus cholecystitis is a complication of gallstones, let's review first what gallstones are, what's the function of our gallbladder and the gallstone. So we all know that the gallbladder is a storage of bile, and it sends the bile to the small intestine after eating fatty meals. When we eat fatty meals, the hormone cholecystokinin or CCK is released from the duodenum, causing contraction of the gallbladder to squeeze out bile into the small intestines, since fatty foods are hard to absorb. So the bile acts like a detergent to emulsify the fat, making it easier to absorb. Next slide, please. So bile salts and acids are products of cholesterol metabolism, in which they both have hydrophilic and hydrophobic ends, making them amphiphilic molecules. And because of that characteristic, they can be soluble in bile. Another component of the bile is phospholipids, which contain lecithins, which are also amphiphilic, hence contributing to the emulsification of cholesterol in the bile. Next slide, please. Recall that there are two types of gallstones. The cholesterol stones and the bilirubin are pigmented stones. Cholesterol stones, they are precipitated cholesterol and occur in 75 to 90% of the cases and is formed through supersaturation of bile with cholesterol. Next slide, please. decreased bile salts and acids, gallbladder hypomotility leading to bile stasis. So next slide, please. So for the gallbladder hypomotility, if the gallbladder emptied all supersaturated or crystal containing bile completely, stones would not be able to grow. So since there's bile stasis, there's a higher chance for the cholesterol to accumulate and increasing the likelihood of stone formation. Next slide, please. Um, Another mechanism could be mucus hypersecretion or biliary sludge. So biliary sludge traps the nucleated crystals, leading to the accumulation of more cholesterol. So this biliary sludge implies the normal balance between gallbladder mucin secretion and elimination has become deranged. The nucleation of biliary solutes has occurred, and this also implies supersaturation of bile with either cholesterol or calcium bilirubinate. Next slide, please. So the next type of gallbladder stone is bilirubin or pigment stones. So by the name itself, bilirubin stones are formed when there's an increased level of bilirubin. It binds to calcium ions, forming calcium bilirubinate. This bilirubin pigment stone is composed of unconjugated bilirubin. Though unconjugated bilirubin is only a minor component of the bile, there are instances that increase the unconjugated bilirubin levels in the body. Next slide, please. Next, please. So in cases of extravascular hemolysis, which occurs every day in the body, the macrophages phagocytized RBCs, leading to the release of unconjugated bilirubin from the heme metabolism. Normally, the unconjugated bilirubin will be brought to the liver, where it is conjugated by adding glucuronic acid and brought to the bile for excretion. In cases of severe extravascular hemolysis, like in some hemolytic anemias, there's also excess of unconjugated bilirubin released, and the liver cannot accommodate conjugating all of them. Hence, the formation of bilirubin calcium salts. Another cause could be the conjugation of excess conjugated bilirubin mediated by endogenous beta glucuronides, but may also occur by spontaneous hydrolysis. Next slide, please. Sometimes, when there's chronic bacterial infection, such stones are brown, and it is a sign of biliary tract infection. Next slide, please. So that is how the coliliths or the gallstones are formed inside the body, and over time, it can complicate into calculus cholecystitis. So for our diagnosis is calculus cholecystitis, and it is precipitated by 90% of cases by obstruction of the cystic duct by a stone. So as you can see in the picture, on the left side is the normal anatomy of our gallbladder. On the right side is how the acute cholecystitis works. So acute cholecystitis results from chemical irritation and inflammation of a gallbladder obstructed by a stone and is evoked by three mechanisms. So as you can see in the picture, the gallstone is obstructing the cystic duct or the neck of the gallbladder. So next slide, please. So here is the diagram of the pathogenesis and its associated clinical findings for acute cholecystitis. So apparently, biostasis triggers the release of phospholipase, which hydrolyzes the luminal lecithins to toxic lysosithins. And this is also called as the chemical inflammation. So since there's irritation of gallbladder wall, um, it stimulates the foregut autonomic nerves, thereby producing dull diffuse abdominal pain that may be felt more in the right upper quadrant of the abdomen, and it may radiate to the back and right shoulder. So this leads to the disruption of the protective glycoprotein mucous layer, exposing the mucosal epithelium to the direct detergent action of bile salts. So the damaged mucosa secretes more fluid into the gallbladder lumen than it absorbs, so which results to distension. So the distension and increased intraluminal pressure compromise the blood flow into the mucosa, leading to ischemia, or also called as the mechanical inflammation. So that triggers cytokine release, causing fever, nausea, or vomiting, and also sometimes tachycardia to the patient. The distended gallbladder will cause a release of prostaglandins, contributing to mucosal and mural inflammation. So all of these events occur in the absence of bacterial infection, but over time, bacterial contamination may develop. So, and if this is untreated, the gallbladder may become fibrotic and contracted, progressing to chronic cholecystitis, or it could become gangrene of the gallbladder or gallbladder perforation. That's all.
So for guide question 2, what factors are associated with this condition? Next, please. So cholecystitis almost always occur in association with gallstones, and its epidemiologic distribution closely parallels that of your gallstones or your cholelithiasis. So as such, the risk factors to cholelithiasis predisposes one to cholecystitis as well. So before listing down the risk factors, we must keep in mind that the gallstones are formed whenever there is an imbalance in bile constituents and or bile stasis, as has been discussed previously. So as mentioned in the lecture, the major risk factors for your gallstone formation are easily recalled through the 4Fs. So fat, 40, female, and fertile. However, now we've added 2 more Fs for easy recall of additional 2 factors, which is your fair and family history. So fat refers to, previous slide please. So fat refers to obesity, metabolic syndrome, or rapid weight loss as your risk factors. 40 and female refer to age and sex as your risk factors. Female and fertile refer to estrogen exposure as risk factors. And these 4 all lead to hypersecretion of your biliary cholesterol, which predisposes to the formation of your cholesterol stones. For your fair and family history, refer to your hereditary factors and race as the risk factors. And this involves mutations in genes responsible for cholesterol transport or impaired hepatic conversion of your cholesterol to your bile acids. So next, please. So from the ones not mentioned in the previous slide, this is a list of the predisposing factors to cholesterol stone formation. So pregnancy is predisposes to cholesterol stone formation due to impaired gallbladder emptying, and still this impaired gallbladder emptying is brought about by the progesterone combined with the estrogen influence that are increased in pregnancy and would lead to increased biliary cholesterol secretion. Increasing age, aside from the increased biliary secretion, presents with decreased size of the bile acid pool and bile salt secretion as well. For your gallbladder hypomotility, this may be triggered or caused by your prolonged parenteral nutrition, fasting, pregnancy, or drugs. And the hypomotility provides a favorable environment for stone formation. Your low fibrate therapy and your high calorie fat diet also increases biliary cholesterol secretion. Then your primary biliary cirrhosis and your CYP7A1 gene defect decreases your bile acid secretion, and hence there is decreased solubilization of your cholesterol in the bile, leading to the formation of stones. Then most importantly, your cholesterol stones are more or less formed or found predominantly in North American Indians, Chilean Indians, Chilean Hispanics, and more in the Northern Europe and America than your Asians. And family disposition and hereditary aspects play a role as well. So next, please. So the predisposing factors for your pigment stone formation. So they are likely formed by Asians and in rural settings. And as mentioned in the pathophysiology, chronic hemolysis, such as your chronic hemolytic anemias, severe ileal dysfunction or bypass, and chronic biliary tract infections and parasitic infections increase the risk of developing your pigment stones because of elevated levels of your unconjugated bilirubin in bile. Then your pernicious anemia results to intramedullary hemolysis, which is one of the risk factors for your gallstone formation. Then lastly, your cystic fibrosis is associated with bile acid malabsorption, due to its binding to undigested dietary nutrients and would lead to the formation of your bile stones.
Treatment and management. Antibiotics for cholecystitis include piperacillin tazobactam combination, ampicillin sulbactam, or meropenem. In severe life-threatening cases, imipenem cilastatin is recommended. Cholecystectomy if complication is confirmed and if gallstones become symptomatic. This is the first-line therapy recommended due to tendency of gallstones to frequently recur. Once gallstone is removed, bile flows directly from the liver into the small intestine. Laparoscopic cholecystectomy is considered the most cost-effective management strategy. Other management include food high in fiber, fewer carbohydrates, and less sugar should be consumed. Losing weight if overweight or obese, and regular physical activity.
So for the prognosis, next slide please. In the United States, 1 million new cases are diagnosed annually, and 2/3 of individuals that are affected undergo surgery. Risk factors include advancing age, wherein less than 5 to 6% are younger than 40 years old, and 25 to 30% are older than 80 years old. Other risk factors include females, estrogen use, obesity, and heredity. It had been present for decades without causing any symptoms, and 70 to 80% remains symptomatic throughout life, wherein the attack will subside in 7 to 10 days and frequently within 24 hours. But 25% of the patients appear symptomatic with severe symptoms and requires immediate surgical intervention. For the mortality rate of elective cholecystectomy is 0.5% with less than 10% morbidity, and emergency cholecystectomy, on the other hand, is 3 to 5% mortality rate with 30 to 50% morbidity.
Are we done? Okay, so yeah, so very well explained, no? Um, you have sorry, video. You have extensively reported and yeah, the extensively reported about cholecystitis as a complication of cholelithiasis, and to add, no, if the patient is has gallstones, even though there's no cholecystitis, but the patient has risk factors, for example, for diabetes. This diabetes really is really an indication for elective cholecystectomy, even if there's no cholecystitis yet. And isa pa man, I think you mentioned about the 4Fs already. What do you call what is Charcot's triad? Charcot's triad of cholecystitis. What is it composed of?
Jaundice, doc, fever, and
Jaundice,
right
fever,
upper
and
quadrant
right
pain.
upper quadrant pain.
Right upper quadrant pain.
Yeah. There's another one, pagali, 4 sila kabuok. It's Charcot's triad plus another one. I forgot it. You can look for that now. Look into that. Okay, so the exam tomorrow, basing on the knowledge that you have poured in now, okay, it's relatively easy already for you because it's you have. I think this class has really done. You've really done your part. Okay, I am impressed. One comment lang sa flow ba, the flow of your discussion, um, please place first the differential diagnosis, the slides for differential diagnosis ahead of your final diagnosis. So different history, then differential diagnosis. After that, your final diagnosis or impression. And in your differential diagnosis, um, we also include already the column for your final diagnosis. Okay, so differential, diba? Usually you put 2 or 3. The fourth column is your final diagnosis, the last one. Okay, because your final diagnosis is still part of your differential. It's just that it's the entity that you choose to become your final diagnosis. Ano lang, that's my comment. The rest, you're already good, no? Section A. Okay. So I hope I already posted some pointers for the practical exam tomorrow. I allow you only 1 hour, maybe extension lang, 1 hour 30 minutes now for those who have connectivity problems. That is just 20 items, and well, you can ace the exam because you have exhaustively explained everything, no? Mas grabe pa yung explanation gali sa akong lecture. So congrats to the ones who have really poured their, no, did their effort, did their part. Okay, in when yeah, this is the purpose of small group discussion. You you cooperate, no, so that you can learn from your pool of knowledge. Okay, any questions, class? Any questions before we call it a day? Okay, nahuman get 2 hours.
Morning,
Yes.
Doc.
Yes, Mr. Rosas.
Related ni siya sa quiz last time, Doc ba? Okay ra if magparasyo mi sa quiz, Doc?
Sa quiz, sige, we'll set a schedule for the for this practical. Ano lang, what I need is a common time. Common time ra gid nato. Through you coordinate with your presidents, then your presidents will tell me when. Okay? Okay?
Thank you, Doc.
Ana lang. I-tell your presidents nga unsa man nga time kamo pod dapat present pod mo. Present pod mo syempre na kay kamo biya nag-request. Ana lang. Okay, pero so far, do you have any questions?
Doc, I mean, Doc, kay ang katong quiz da ay Doc last week, Doc ba?
So, katong pre-test. Sige, you want it now? Ay pa ha. Wait lang. Ay, wala ka. Nice to... do you want me to include this in the recording, the ratio, or gusto na lang? Ako na lang na-stop ang recording?
Up to you lang, Doc.
Up to me
okay
lang.
Ra.
Sige. Let's go. Then share screen man na, share screen. Wait lang ha. What you're talking about is the pre-test, the post-test. Wait lang, I'm gonna share my screen. Saan na to siya? Sorry. Hindi. Wait lang ha. Okay, can you see this? Can you see the ano? Can you see?
Yes, Doc.
Yes, Doc.
This is your post test, last time. Okay, so I combined the lecture and lab. So okay, choose the appropriate. So what is this? This is very obvious. What's diagnosis? What's the diagnosis? Come on, tubag. What's the diagnosis? President.
Steatosis.
Lipid vascularity.
Oh, diagnosis
Steatosis.
lang. Oh, what is this? Fatty liver, di ba? Steatosis. Di ba? You see lipid vacuoles, the nucleus is pushed to one side. Okay, everyone agrees?
Yes, Doc.
Yes, Doc.
Okay, sige. So, the answer is lipid vacuolization. No? Next, kini. What is this? You see red blood cells. Luwag man yung picture, no? Pero, ana. What is the hallmark? What is this? What is the diagnosis? Basta red blood cells leaking out. What is that?
Chronic passive congestion.
Okay, passive congestion. Okay, so the hallmark is RBC leakage. Okay, next. Kana, very clear. What is being emphasized here is the fibrosis between portal lobules, no, or sodial lobules. What is this? What is the diagnosis?
Cirrhosis.
Cirrhosis. Oh, so hallmark is portal fibrosis. Next. Kene, what is this? Is this still the liver? Not anymore. Not anymore. This is the gallbladder. So liver and gallbladder raman ta. So kung dili liver, gallbladder, di ba? Okay, so you notice the biliary epithelium, okay, columnar. Then what is this structure here? What's the diagnosis here? You see lymphocytes in the lamina propria.
Cholecystitis.
Okay, so
Chronic cholecystitis.
Chronic cholecystitis. And what's the hallmark? So one of the hallmarks is the presence of glands in the lamina propria. This is the Rokitansky-Askoff sinuses. Mga glands, these are glands that are embedded inside ba? Okay. So that's Rokitansky-Askoff sinuses. Next, choose the appropriate hallmark for the whole. What's the diagnosis here? Very prominent nuclei. This is liver, di ba? Basta prominent ang nuclei. You see, stages of mitosis. That is
Hepatocellular carcinoma.
Liver cancer, Doc.
Basta, ang ganit class, when I was a student ba, we have really lots of, sa lecture, we get confused man kay lots of things to study. But in the lab, we only have these like, in our case, 10 slides, di ba? 10 slides, then each slide has its own hallmark. Each slide has its own hallmark. So we cannot be confused anymore, no? So like this one, you see the nucleus very prominent, then that's then there's no other choice but hepatocellular carcinoma. Okay? So, zoom in the pictures below kay lubog ni kanang gagmay ganyang di ko kabalo sa pagpadako ba sa Google Classroom. So, choose the appropriate slide for each hallmark. The hallmark is single or few big pockets of lymphocytic infiltration. So, to facilitate, ato na lang ni i-diagnose each ha. Ini siya. What is this? You see, what is this? Ini. These are infiltrates. Huh? These are infiltrates. Okay. What are these?
Parasitic eggs.
Okay, parasitic eggs pero unsa man ni siya? This is
Schistosoma.
dili siya schistosoma because schistosoma is found number one, schistosoma is stained violet, no? Kung kini nga siya nga stain. This one is amoebic abscess.
Amoeba, Doc.
Amoeba.
Amoeba.
Trophozoite na siya. Okay? Trophozoite. Okay. Next, this one.
Pyogenic.
Okay, pyogenic abscess. So, di ba previously in you had pulmonary pathology naman, di ba? And you had that slide of pulmonary abscess. Yeah, that pulmonary abscess is still pyogenic in nature, no? Streptococcus pyogenes pag ito, di ba? This one is just that the same cause but different location. It's in the liver. Okay. Okay. Next. Kini siya. What is this? You see the liver cells, hepatocytes, and you have infiltrates. Is this still an abscess?
Typhoid, Doc.
Okay, typhoid, di ba? Ang typhoid, in typhoid, the infiltrates insert in between the hepatocytes. So, lahi man siya. Ang abscess man good, like pyogenic abscess, the infiltrates really collect in one area, no? And here, di man. Okay. Next, this one. Oh, this one is you have infiltrates, but very obvious, no? The staining of the eggs, schistosomiasis. Okay. Well, schistosomiasis, look for the eggs stained violet, no, darkly stained. Mang problem na lang ana is if there's no stain, no? But yeah, mantanan man stained. Pictures man po ipakita nato, no? Okay, next, this one. What's the diagnosis? Take note. Yeah, liver cells, portal, the portal tracts. What is this? These are proliferation of bile ducts. Okay, diagnosis?
Biliary cirrhosis.
Biliary cirrhosis. So biliary cirrhosis. So can we tell that? Can we tell if it's primary or secondary, basing on the slide? No. Basta biliary cirrhosis na siya. So let's go back, ha? Klaro ra, class? No? So single or big few pockets of lymphocytic infiltration. Now lymphocytic, so infiltration pockets man, so that is abscess, singular or few. So it in the answer here is amoebic abscess. Okay, amoebic abscess. Because in amoebic abscess, mas dagko man siya, dagko iyang abscess compared sa pyogenic. And the infiltration in amoeba is lymphocyte compared to pyogenic abscess, the infiltration is neutrophils. That's why the next number is multiple pockets, so the kind of small pockets of neutrophilic infiltration, then this is pyogenic abscess. Okay, clear. Next here.
Yes, Doc.
Multiple patches of macrophage infiltration. So patches, no? Patches. So the answer is typhoid. Patches naman, dili man siya pockets good. Mura siya insert lang siya ba? Patches lang. So this is typhoid nodule. Next. Parasitic eggs in the portal areas. So here, schistosomiasis. Oh, can you still hear me?
Yes,
Yes, Doc.
Doc.
Okay, my internet connection is unstable though. The biliary proliferation, so that the last one, biliary cirrhosis. Ano lang, no? So what's the cause of biliary proliferation? It's biliary destruction. So it depends you are dealing with primary biliary cirrhosis and it's autoimmune. Secondary to cholelithiasis, cholecystitis, parasitic infection, and here. The root cause of alcoholic fatty change. So we have, di ba, the pathophysio of fatty change is varies man depending on the cause. No, we just know that the fatty change is secondary to under under excretion of this lipid products or under excretion or over secretion, no? So basta na accumulation of fat, no, in the liver. So number one, for alcoholic, then it's decrease NAD, nicotinamide adenine. Okay. Next. So this one, what's for insulin resistance? This pertains to non-alcoholic fatty change, fatty liver. For mitochondrial injury, is for drugs and toxin. No? Okay. And the rest, ako na nang idugang-dugang. Then, majority of hepatitis B cases go to chronic phase or go to recovery.
Recover, Doc.
Recover. Majority recover good. Recover. Okay. And main pathophysiology of ascites in cirrhosis. So the question is main pathophysiology. Actually, when if the question is pathophysiology lang, there are two answers, but the question is main pathophysiology. Then it's secondary to the portal hypertension. Okay. Okay. Pero if the question is what are the two pathophysiologic mechanisms for ascites in cirrhosis, then the other answer is also this one, decrease oncotic pressure due to decreased albumin synthesis. Okay. Hepatic adenomas are benign except those with mutation in
Beta-catenin, Doc.
beta-catenin. And effect of aspirin towards the liver in Rye syndrome. What is Rye syndrome? So it occurs in it's liver failure secondary to excessive administration of aspirin, no, on children siya. Before mothers give aspirin to fever but to febrile children. Now it's already prohibited. Use paracetamol, but paracetamol also has its own side effects. So what's the answer?
Fulminant hepatitis.
Fulminant hepatitis. Okay. Majority of the serology in primary sclerosing cholangitis are positive in
Anka, Doc.
ANCA siya. ANCA ang PSC, no?
Anka, Doc.
ANCA. But for PBC, the primary biliary cirrhosis, it's AMA. Okay? So PSC,
AMA.
ANCA, then PBC, AMA. Okay? The most common overall cause of hemochromatosis. What's the answer?
Mutation, Doc.
Okay, so
HFE.
it's hereditary, no? Hereditary HFE mutation. But these are all causes for hemochromatosis. Next, night blindness is a consequence of malabsorption of fat-soluble vitamins due to
biliary obstruction.
actually two answers. Basta the main explanation here is you have the end effect is malabsorption. So there shouldn't be bile that should be produced in the duodenum, di ba? So there are two answers, defective bile production and biliary obstruction. Ano pa din? Pigment stones caused by intravascular hemolysis are made of bilirubin that is
unconjugated.
Unconjugated. Basta hemolysis, unconjugated. Intraepithelial biliary neoplasia will progress to
cholangiocarcinoma, Doc.
Cholangiocarcinoma. Okay. Then, kana lang. Moro na siya. I have questions like this in the unit exam, no, mga short questions na. But majority, it's like 25 short questions, then the 35 are cases. Okay, so you study cases po. Okay? Sige, any questions? Happy?
Yes, Doc. Thank you, Doc.
Okay. Sige, ang sama na. Stop screen sharing, no? First time di ako mag-screen share. How do I stop share? Okay. Ana lang. Okay, so I think we are all hungry. Are you hungry? Let's eat now. Sige, we'll call it a day.
Yes, Doc.
Thank you so much, class. So if you have any questions, the most convenient way is to channel it through your presidents. Okay. Thank you so much. And good luck.
Thank you, Doc.
Thank you, Doc.
Thank you, Doc.
Thank you and goodbye, Doc.
Okay, you too.
Thank you, Doc.
Thank you, Doc.